Veterans Memorial Medical Center. She is an active consultant to the following hospitals in Bulacan: Sacred Heart Hospital Malolos, Castro Maternity Hospital and Medical Center Baliwag, Ace Medical Center Baliwag. Let's all welcome Dr. Jericel R. Bugay.
Hello, everyone. Let me welcome you once again to this Pediatric ICU Forum. We are now on the fifth station of the Pediatric ICU Most Requested Topics Season 2. In this station, we will be talking about an interesting and equally important topic in pediatric critical care, and that is all about glucose control and management. A frequent feature of critical illness is a disturbed homeostasis, and this is very true in terms of glucose regulation. In fact, alteration in blood sugar levels are among the most frequently encountered components of a disturbed homeostasis in critically ill patients, both in adult and pediatric ICU. It is often said that when we manage a critically ill child, we should not forget to ask the question, how is this child's glucose? Recent evidences have shown that glucose variability may have adverse outcomes in critically ill patients. Indeed, it is no sweet talk on blood sugar in pediatric ICU. In this station, we have two distinguished pediatric intensivists who will be discussing glucose dysregulation, control, and management in both diabetic and non-diabetic patients. So, all aboard this fifth station, just sit back and relax while we watch, listen, and learn on today's PICU M.R.T. No Sweet Talk on Blood Sugar in PICU. Let me introduce our first speaker, Dr. Paul D. Covarrubias. Doc Paul is a graduate of University of Santo Tomas. He finished his residency training in pediatrics at UST Hospital and fellowship training in pediatric critical care at Philippine Children's Medical Center. He was a rotating fellow at Johns Hopkins Medical Institution in Baltimore, Maryland. He also completed his master's in management, major in health administration at Philippine Christian University. Doc Paul is a fellow of the Philippine Pediatric Society, a fellow of the Society of Pediatric Critical Care Medicine Philippines, and a fellow of the Philippine Society of Critical Care Medicine. He is one of our well-respected pediatric intensivists in NCR and is affiliated in St. Luke's Medical Center Global City, Marikina Valley Medical Center, Diliman Doctors Hospital, Amang Rodriguez Memorial Medical Center, Hospital ng Makati, and Quirino Memorial Medical Center. To talk on controlling sugars on the rise, a talk on diabetic ketoacidosis in children, here is Dr. Paul D. Covarrubias.
Good afternoon and welcome to PICU M.R.T. series. Before I begin, let me thank Dr. Roda Cipriano and Dr. Pai Evangelista for the invitation and to Delex Pharmaceutical for this opportunity to discuss with you an illness that is often misdiagnosed on initial presentation that poses a threat on the outcome in most children. DKA is the leading cause of morbidity and mortality in children with type 1 diabetes mellitus and occurs in approximately 30% of children at the time of diagnosis of type 1 diabetes in the United States and Canada. As compared to children with established diabetes, DKA occurs at a rate of 6 to 8% per year. Our local data from the Philippine Pediatric Society Registry dated January 2006 to June 2022 shows that there are 1,495 cases among type 1 diabetes mellitus, 123 cases for type 2 diabetes mellitus and 402 DKA cases for those unspecified diabetes mellitus. By definition, DKA follows some biochemical criteria that includes hyperglycemia, metabolic acidosis, and ketosis. In contrast, hyperglycemic hypersmolar state is a hyperglycemic emergency. Occurs most commonly in adults with poorly controlled type 2 diabetes, but has also been reported in children and usually presents with altered consciousness. It is very important to have a high index of suspicion to initiate appropriate management and improve clinical outcome. Here are identified risk factors for DKA in an undiagnosed type 1 diabetes mellitus. Young age less than 5, especially less than 2 years, low socioeconomic status, ethnic minority, delayed diagnosis, children living in countries with low prevalence of type 1 diabetes. Shown as well are the identified risk factors for DKA among those diagnosed with type 1 diabetes. These include poor metabolic control, gastroenteritis with vomiting and dehydration, peripubertal and pubertal adolescent girls, history of psychiatric disorders, limited access to medical care, inadvertent or intentional omission of insulin, including failure of insulin pumps. Common precipitating factors for DKA include the following. In many cases, multiple precipitating factors coexist. Insulin omission and other diabetes mismanagement accounts for the majority of DKA episodes in children with established diabetes. Omission of insulin injections, both intentional or unintentional, is particularly frequent among adolescents. Intercurrent illnesses, particularly when associated with vomiting and dehydration, can precipitate DKA by increasing stress hormone levels that increase hepatic glucose output, cause peripheral insulin resistance, and promote ketogenesis. Illnesses involving vomiting are particularly problematic because they interrupt food intake, often requiring a reduction in the amount of insulin administered. Patients may completely omit insulin in an effort to avoid causing hypoglycemia. Certain medications like steroids that have been shown to trigger DKA in individuals not previously diagnosed with type 1 diabetes mellitus. Use of corticosteroids in children with established diabetes can lead to insulin resistance, leading to hyperglycemia and occasionally ketosis. Among teens, use of illicit drugs and alcohol may interfere with compliance to medical management recommendations, resulting in poor metabolic control, which increases the risk for DKA. Insulin deficiency and increased plasma concentrations of counter-regulatory hormones like glucagon, cortisol, and epinephrine increase glucose production, lipolysis, and ketogenesis, which collectively contribute to the development of both hyperglycemia and ketoacidosis. To reiterate, clinical diagnosis of diabetes in a previously healthy child requires a high index of suspicion. Signs and symptoms of DKA are the result of acidosis, hyperglycemia, volume depletion, and electrolyte losses. Early symptoms are related to hyperglycemia and are most apparent in older children and adolescents. In infants, the diagnosis is more difficult because of lack of toilet training and difficulty expressing thirst. As a result, polyuria may not be appreciated and polydipsia may not be apparent. However, decreased energy and activity, irritability, weight loss, and physical signs of dehydration are common findings. In addition, severe candida diaper rash should raise suspicion for diabetes. Common manifestations include anorexia, nausea, vomiting, and abdominal pain that mimics acute abdominal condition. Polyphagia may be present early in the course of the illness. However, once insulin deficiency becomes more severe and acidosis develops, appetite is suppressed. Hyperventilation and diffuse respirations represent the respiratory compensation for metabolic acidosis. Hyperpnea results from an increase in minute volume, which is respiratory rate times the tidal volume, and can be increased by tidal volume alone without an increase in respiratory rate. In infants, hyperpnea may be manifested only by tachypnea. Patients may also have a fruity breath odor secondary to exhaled acetone. Clinical signs of intravascular volume depletion occur but tend to be less prominent compared to patients with the same degree of fluid loss from other conditions because the intravascular volume is relatively preserved due to increased intravascular osmolarity from hyperglycemia. Urine output is preserved because of hyperglycemia-induced osmotic diuresis. Neurologic findings are mainly related to the degree of acidosis. It is very important to understand the goals of therapy when managing DKA. This entails close monitoring of biochemical parameters to correct acidosis and reverse ketosis. Appropriate use of IV fluid to correct dehydration, restoring blood glucose to near normal, anticipatory care for possible complications and treatment if recognized, and lastly, identifying and treating any precipitating events like possible infection. Current recommendations are based on available evidences and are only intended as a general guide in DKA management. Individual variability in presentation ranging from mild with only minimal dehydration to severe with profound dehydration or shock may require specific treatment that, in the judgment of the attending pediatrician, may be within or occasionally outside the range of options or recommendations. Emergency assessment should follow the general guidelines for pediatric advanced life support or PALS. Initial evaluation, recognition, and appropriate management is very crucial for early reversal of DKA in children, as well as in the prevention of complications that may arise during course of treatment. Failure to recognize such problems may increase morbidity and mortality. General resuscitation follows the ABC, which stands for proper positioning of airway and maintaining its patency. In the presence of altered sensorium, insert artificial airways. B for breathing by providing 100% oxygen delivery through face mask to all patients with circulatory impairment or shock. C for circulation, making sure a reliable vascular access for administration of fluids and medications. A second peripheral IV line should be placed for convenient and painless repetitive blood sampling. Insulin infusion should not be interrupted when other fluids are given through the same line. Continuous monitoring of vital signs as well as ECG monitoring for evidence of hyper or hypokalemia. If a patient will present unconscious or severely obtunded without airway or normal airway protective reflexes, secure the airway and empty the stomach by continuous nasogastric suction to prevent pulmonary aspiration. Intubation, if possible, should be avoided. If there is recent large consumption of glucose-containing fluids like fruit juice or sweetened soft drinks, consider emptying the stomach even in patients who are not obtunded. The stomach may contain large volume of water with little amount of sodium, which is the absorption of glucose and electrolyte-free water from the intestinal tract. As to how oxygen should be administered, children with DKA may present with respiratory symptoms, which oftentimes can be misdiagnosed to have a pulmonary pathology. Although oxygenation may not be an issue, DKA oftentimes may present with labored work of breathing that could eventually lead to respiratory fatigue. Most common oxygen support given to patients is the nasal cannula. This low-flow device delivers varying inspired oxygen concentration depending on the respiratory rate and effort, and of course the size of the child. As long as the flow of oxygen, that is the oxygen in liters per minute, exceeds the maximal inspiratory flow rate, the desired concentration of oxygen or FiO2 will be delivered. For young infants, even at 2 liters per minute, an inspired oxygen concentration of more than 50% can be delivered and often better tolerated than face masks. Nasal cannula is suitable for children who require modest oxygen supplementation. Flow rates of more than 4 liters per minute for prolonged periods are often poorly tolerated because of the drying effect on the nasal mucosa. For patients with effective spontaneous ventilation, a simple face mask to provide oxygen at a concentration of 30 to 50% can be sufficient. However, if a higher concentration of oxygen is desired, it can be administered using a non-rebreathing mask with a flow rate of up to 15 liters per minute. Use of non-rebreather mask should be considered, especially if there is a suspected primary hypoxic issue like altered mental state or seizures. High flow nasal cannula delivers high FiO2 compared to other oxygen delivery systems through a higher flow rate of up to 70 liters per minute, which in most cases exceeds the patient's peak inspiratory flow rate, preventing possible intubation. One advantage is that it can also generate low level of positive pressure or PEEP in the upper airway, which is directly proportional to gas flow delivered that improves oxygenation. It delivers an adjustable mixture of heated and humidified air and oxygen at rates that exceed spontaneous inspiratory flow. For non-invasive ventilation, oxygen is delivered with interface that rather than endotracheal tubes such as the nasal or a nasal mouthpieces and helmets, which are connected to the face and
Recording in
collapse and
progress.
apnea during intubation, and will cause their PCO2 levels to rise rapidly, increasing PCO2 during or following intubation above the may cause spinal fluid and contribute to worsening of sleep in patients with DKA would depend on the clinical status of per deciliter is generally required for diagnosis of DKA in osmotic diuresis with polyuria. Volume depletion occurs when fluid losses are not sufficiently compensated with increased fluid intake. Acidosis defined as venous pH of less than 7.3 or 0 by current concentration of the 50 milliequivalent per liter. Most accurate measure of acids, however, especially in resource-limited settings and are closely correlated with venous pH. Ketosis can be estimated through serum beta-hydroxybutyrate and is the most accurate clinically eventually determines presence of ketosis acidosis expected to have type 2 diabetes. Potentials with particular controversy on optimal fluid management. With hyperglycemia, there is osmotic diuresis, which result in significant with viscosity will restore intravascular volume, achieve normal tonicity, improve organ preservation, improve functions of serial injury, administration,
Recording in
in young
progress.
children aged 1 month to 5 years. Useful signs include prolonged capillary refill time, normally less than 2 seconds, abnormal skin turgor, dry mucous membranes, sunken eyes, absent tears, weak pulses, cool extremities. For more than 10% dehydration, presence of weak or impalpable peripheral pulses, hypotension, oliguria may be present. There is generally fair to moderate agreement in the estimation of the degree of dehydration among examiners. McKinsey et al. Found four signs of pediatric patients with gastroenteritis that best predict the dehydration, namely prolonged capillary refill time, absence of tears, dry mucous membranes, and overall appearance of illness. Murphy et al. Found that the most valuable signs of assessing dehydration in gastroenteritis were decreased skin turgor, dry oral mucosa, sunken eyeballs, and altered neurological status. However, none of these clinical parameters by McKinsey and Murphy were found to be good predictors in a study involving children with DKA. Very helpful in evaluating dehydration is recalling the criteria for diagnosis. Metabolic acidosis causes a decrease in peripheral vascular resistance, decrease in cardiac ventricular function, and compensatory hyperventilation. Hyperglycemia induces osmotic diuresis, but free water losses frequently exceed sodium losses. Understand that serum sodium concentration is not a reliable measure of the degree of ECF contraction because glucose is largely restricted to the ECF space that causes movement of water into the extracellular space, causing dilutional hyponatremia. Checking on urine-specific gravity is neither a valid test due to glucosuria and ketonuria, making urine-specific gravity inaccurate for assessing dehydration severity. Increased blood urea nitrogen concentrations and elevated hematocrit can be helpful markers of hydration status. DKA who are volume depleted but not in shock should immediately receive a 0.9% normal saline solution to restore peripheral circulation administered at 10 ml per kilogram infused over 30 to 60 minutes. However, if tissue perfusion is poor, give the initial fluid more rapidly over 15 to 30 minutes. A second fluid bolus may be needed to ensure adequate tissue perfusion. However, if in shock, rapidly restore circulation volume with isotonic fluid at 20 ml per kilogram. Bolus infused as quickly as possible with reassessment of circulatory status after each bolus. As clinical evaluation may be not accurately assess the degree of dehydration, estimation of fluid deficit should be based on the initial blood pH. Venous pH is the most accurate measure of acidosis. However, in resource-limited settings, measurement of serum bicarbonate may be used and is closely correlated with venous pH. A blood pH of 7.2 to 7.9 and oral bicarbonate of less than 15 assume a 5% fluid deficit or mild DKA. A blood pH of 7.1 to 7.19 and oral bicarbonate of less than 10 assume 7% fluid deficit or moderate DKA. A blood pH of less than 7.1 and oral bicarbonate of less than 5 assume 10% fluid deficit or severe DKA. The fluid deficit should be replaced over 48 hours alongside maintenance fluids. Just to show the tabulated severity assessment of DKA in children, let's compute the fluid deficit which will be given over 48 hours. So if a patient weighs 25 kilograms with initial blood gas showing pH of 6.9 and unreadable bicarbonate, the initial resuscitation of plain NSS at 10 ml per kilogram bolus was given. Since the patient was not in shock, the initial volume of 250 ml should be subtracted from the total calculated fluid deficit of 2,500 to be replaced over 48 hours alongside with the maintenance fluids computed using the holiday cigar. But if the patient presented with shock, Rapid administration of 20 ml per kilogram as bolus using plain NSS with reassessment of circulatory status after IV fluid infusion. Assuming he receives 20 ml per kilogram or 500 ml of 0.9 NSS for resuscitation, his fluid deficit will be 100 ml per kilogram distributed over 48 hours. To re-emphasize, the volume of fluid boluses given for resuscitation in DKA with shock should not be subtracted from the estimated fluid deficit. There are three methods for determining maintenance fluid requirements in children, which we commonly use. The holiday cigar, the simplified holiday cigar formula, which is 4 ml per kilogram per hour for less than 10 kilograms, 40 plus 2 ml per kilogram per hour for each kilogram between 11 to 20, and 60 plus 1 ml per kilogram per hour for each kilogram more than 20 kilograms. Formula using body surface area for children weighing more than 10 kilograms is computed at 1,500 ml per meter square for 24 hours. Maintenance electrolyte requirements in children are given per 100 ml of maintenance IV fluids. For obese patients, fluid calculation should be based on an approximation of ideal body weight for height to avoid excessive fluid administration. All children will experience a decrease in the vascular volume and plasma glucose concentration fall during treatment. Therefore, make sure that patients receive sufficient fluids with a tonicity of 0.45 to zero point 0.9 saline to maintain good tissue perfusion. Use of isotonic versus hypotonic solution should depend on clinician's judgment based on the patient's hydration status, serum sodium concentration, and osmolality. Oral intake may begin within 24 hours. This table from the International Society for Pediatric and Adolescent Diabetes, or ISPAD, gives a rapid guide for the maintenance and replacement volume with severe DKA based on body weight. At this phase, calculated effective osmolality is a valuable guide to fluid and electrolyte therapy. Aim to gradually reduce serum effective osmolality to normal. Serum sodium should be measured every 2 to 4 hours during treatment, and there should be a concomitant increase in serum sodium by 0.5 millimoles per liter as glucose concentration decreased by 18 milligrams per deciliter. However, if serum sodium is low and does not rise appropriately, the sodium content of the fluid should be increased. Shown is the formula for effective osmolality, which normally is between 275 to 295 milliosmol per kilogram. With insulin infusion, it reduces normal cellular metabolism, offsets insulin resistance, suppresses hepatic glucose output and ketogenesis, stimulates peripheral glucose uptake and metabolism, lowers serum glucose concentration, and helps resolve ketosis. However, give insulin infusion at least an hour after giving fluid replacement therapy. It will lower the serum glucose concentration by dilution and via improvements in renal perfusion. Insulin infusion rates at 0.05 versus zero point 0.1 units per kilogram per hour to achieve the blood glucose targets of 250 milligrams per deciliter. A small randomized controlled trial in children less than 12 years old showed that low dose at 0.05 units per kilogram per hour was comparable to standard dose of 0.1 unit per kilogram per hour with respect to the rate of blood glucose decrease and resolution of acidosis. However, there was also no evidence that a higher dose of 0.1 unit per kilogram per hour is harmful. IV bolus is unnecessary and should not be used at the start of therapy. It may increase the risk of cerebral edema and can precipitate shock by rapidly decreasing osmotic pressure and exacerbate hypokalemia. Insulin has an aldosterone-like effect leading to increased urinary potassium excretion. High doses administered intravenously for a prolonged period of time may contribute to a decline in serum potassium concentration due to increased urinary potassium excretion despite potassium administration. To prevent a rapid decrease in plasma glucose concentration and hypoglycemia, 5% glucose initially should be added to the IV fluid when the plasma glucose falls approximately 250 to 300 milligrams per deciliter. It may be necessary to use 10% or even 12.5% dextrose to prevent hypoglycemia while continuing to infuse insulin to correct metabolic acidosis while preventing hypoglycemia. A two-bag system is an efficient method to maintain the patient's blood glucose in an acceptable range. In this technique, two bags of the selected IV fluid solution are infused concurrently, one containing D10 dextrose and the other containing no dextrose. Severe acidosis is reversible by fluid and insulin replacement. Acetoacetate is the initial ketone formed and is reduced to beta-hydroxybutyrate or decarboxylated to acetone. When insulin is started, metabolism of the keto acid anion results in the recognition of bicarbonate and correction of the metabolic acidosis. For this reason, keto acid anions have been called potential bicarbonate, and their loss in the urine represents the loss of bicarbonate. Treatment of hypovolemia improves tissue perfusion and renal function, thereby increasing the excretion of organic acids. However, large amount of chloride-rich fluids combined with preferential renal excretion of acetone or ketones over chloride may be associated with the rapid development of hyperchloremia. When hyperchloremia develops, a persisting base deficit or lower bicarbonate concentration can be erroneously interpreted as ongoing ketosis. Measurement of urine ketones with test strips based on the nitroprusside reaction measures acetoacetate and acetone but not beta-hydroxybutyrate, which makes up 75% of circulating ketones. During recovery from DKA, beta-hydroxybutyrate is converted to acetoacetate and acetone, which are excreted in the urine for several hours after the serum beta-hydroxy concentration has returned to normal. Persistent ketonuria characteristically occurs for several hours after serum sodium beta-hydroxybutyrate levels have returned to normal. This means the mean anion gap for DKA in children at presentation is around 30 plus or minus 3 millimoles per liter, while the normal anion gap is at 12 plus or minus 2 millimoles per liter. A normal anion gap acidosis or hyperchloremic acidosis is oftentimes seen during treatment phase of DKA as a result of keto acid loss, as well as the high chloride content of intravenous fluids. Bicarbonate therapy generally should not be used in children with DKA. Potential risk from bicarbonate therapy includes cerebral edema, hypokalemia, hyperchloremic acidosis, hypoglycemia, inadequate rehydration. However, in situations like severe acidosis resulting in hemodynamic instability or life-threatening hyperkalemia, cautious administration of bicarbonate therapy can be considered. TKA have a total body sodium deficit ranging from 5 to 13 millimoles per kilogram. Hyperglycemia tends to lower the serum sodium concentration by dilution because it increases plasma osmolality, resulting in the movement of water from the intracellular to the extracellular space due to osmotic forces. Glucosuria-induced osmotic diuresis tends to raise the serum sodium concentration through water loss in excess of sodium. This effect may partially correct the hyponatremia caused by hyperglycemia. If serum sodium is low and does not rise appropriately, the sodium content of the fluid should be increased. It is also useful to calculate the corrected sodium concentration, which represents the expected serum sodium concentration in the absence of hyperglycemia. It assesses the magnitude of sodium and water deficit. As plasma glucose concentration decreases after giving fluids and insulin, the serum sodium concentration should increase and the glucose-corrected sodium concentration, as shown, should slowly decrease or remain in the normal range. Remember that increase in serum sodium concentration does not indicate a worsening of the hypertonic state, but failure to rise or a further decrease in serum sodium with therapy of insulin is thought to be potentially ominous sign of impending cerebral edema. The estimated potassium deficit in children with DKA is around 3 to 6 millimoles per kilogram. Major loss of potassium is from the intracellular pool caused by transcellular shift caused by hypertonicity, acidosis, glycogenolysis, and proteolysis, which may cause efflux of potassium from the cell. Despite of these levels are usually normal or slightly elevated. Other causes of potassium deficit include urinary potassium loss from osmotic diuresis and ketoacid excretion. Secondary hyperaldosteronism in response to intravascular volume depletion also increases renal potassium loss. Additional losses through vomiting and diarrhea in the case of DKA triggered by gastroenteritis. Replacement therapy is required regardless of the serum potassium concentration except if renal failure is present. If patient is hypokalemic, potassium replacement should be started immediately and the insulin infusion should be delayed until serum potassium has been restored to a near normal concentration. If the patient is normokalemic, potassium replacement should be given at the start of insulin therapy. But if patient is hyperkalemic, defer potassium replacement initially, but should be initiated when the serum potassium falls to normal or after verifying urine production or adequate renal function. Serum potassium concentration should be monitored and the replacement adjusted as needed. ECG showing prolongation of the PR interval, T-wave flattening and inversion, ST depression, prominent Q waves, apparent long QT interval, indicates hypokalemia, while tall peak symmetrical T waves and shortening of the QT interval are signs of hyperkalemia. Start potassium concentration at 40 millimoles per liter and subsequent potassium replacement should be based on potassium measurements. With initial rapid volume expansion, a concentration of 20 millimoles per liter should be used, especially in hypokalemia. Potassium phosphate may be used together with potassium chloride or acetate. But remember, administration of potassium entirely as potassium chloride contributes to hyperchloremic metabolic acidosis, whereas administration entirely as potassium phosphate can result to hypocalcemia. Continue potassium replacement throughout fluid therapy. The recommended maximum rate of IV potassium replacement is usually 0.5 millimoles per kilogram per hour. If hypokalemia persists despite a maximum rate of potassium replacement, consider reducing insulin infusion rate. For profound hypokalemia of less than 2.5 millimoles per liter in untreated DKA, vigorous potassium replacement while delaying the start of insulin therapy until serum potassium levels are more than 2.5 to reduce the risk of cardiopulmonary and neuromuscular compromise. Negative phosphate balance occurs as a result of decreased phosphate intake and phosphaturia caused by glucosuria-induced osmotic diuresis. Plasma phosphate levels fall after starting treatment, and this is exacerbated by insulin infusion, which promotes entry of phosphate into cells. Total body phosphate depletion has been associated with a variety of metabolic disturbances. Severe hypophosphatemia can result during treatment, especially when combined with phosphate depletion. Although uncommon, can have severe consequences. Manifestations depend on the severity and chronicity of symptoms until plasma phosphate is less than 1 milligrams per deciliter. These include metabolic encephalopathy like irritability, paresthesia, confusion, seizures, or even coma. Impaired metabolic contractility and respiratory failure due to weakness of the diaphragm. Muscle dysfunction, dysphagia, and ill use. Rare hematologic effects and rhabdomyolysis are also seen. Administration of potassium phosphate may induce hypocalcemia, so careful monitoring of serum calcium should be done. The incidence of cerebral edema in DKA is zero point 0.5 to zero point 0.9 with mortality rate of 21 to 24%. Mental status abnormalities measured as Glasgow Coma scores less than 14 occur in 4% to 15% with evidence of cerebral edema on neuroimaging. Neuroimaging studies have shown cerebral edema is not a rare phenomenon in children with DKA, but occurs frequently with varying severities. Pathogenesis is incompletely understood. Some have explained the pathogenesis as a result of rapid fluid administration with abrupt changes in the serum osmolality. However, more recent studies have found that dehydration and cerebral hypoperfusion may be associated with DKA-related cerebral injury. It is also noteworthy that the degree of cerebral edema that develops during DKA correlates with the degree of dehydration and hyperventilation at presentation, but not with the initial osmolality or osmotic changes during treatment. Disruption of the blood-brain barrier have been found in cases of fatal cerebral edema with DKA, which further supports the view that cerebral edema is not simply caused by a reduction in the serum osmolality. Demographic factors associated with increased risk include younger age, new onset diabetes, longer duration of symptoms. These risk association may reflect the greater likelihood of cerebral decay, severe DKA. These are some of the identified potential risk factors for cerebral edema at diagnosis or during treatment of DKA. Greater hypocapnia after adjusting the degree of acidosis, increased urea nitrogen, severe acidosis, bicarbonate treatment, early decrease in serum effective osmolality, attenuated rise in serum sodium, or an early fall in glucose-corrected sodium during therapy, greater volumes of fluid given in the first 4 hours, and administration of insulin in the first hour of fluid treatment. Clinically significant cerebral edema usually develops within the first 12 hours after treatment has started, but can occur before treatment has begun or rarely may develop as late as 24 to 48 hours after the start of treatment. Signs and symptoms are variable, although mild to moderate headache at presentation may not be unusual. Development of a severe headache after commencing treatment is always alarming. Initiate treatment as soon as the condition is suspected with head of the bed elevated at 30 degrees. Adjust fluid administration rate as needed to maintain normal blood pressure while avoiding excessive fluid administration that might increase cerebral edema formation. Avoid hypotension that might compromise cerebral perfusion pressure as well. Hyperosmolar agents should be readily available at bedside. Mannitol at zero point 0.5 to 1 gram per kilogram IV over 10 to 15 minutes. The effect of mannitol should be apparent after 15 minutes and is expected to last for about 2 hours. If necessary, the dose can be repeated after 30 minutes. 3% hypertonic saline at 2.5 to 5 ml per kilogram over 10 to 15 minutes may be used as alternative to mannitol or in addition to mannitol if there has been no response to mannitol within 15 to 30 minutes. Let me share this clinical trial of fluid infusion rates and its effect on pediatric DKA by Nathan Copperman for the Pediatric Emergency Care Applied Research Network or PICARN DKA Fluid Study Group published in the New England Journal of Medicine in June 2018. This study was conducted in 13 centers using randomized controlled trial, examining the effects of IV fluid administration rate and sodium chloride content of intravenous fluids on neurologic outcomes in children with DKA. 1,255 patients underwent randomization initially. Of the 1,255 patients, 132 had a second episode of DKA and underwent second randomization, and two additional patients had a third episode of DKA inadvertently underwent randomization for the third time. A total of 1,389 distinct episodes of DKA were evaluated. Children were randomly assigned to one of the four treatment groups in a 2 by 2 factorial design. IV fluid use were zero point 0.9 or 0.45 sodium chloride content, and rapid fluid deficit administration was given in 24 hours, while slow fluid deficit administration was administered in 48 hours. The primary outcome was deterioration of neurologic status evidenced by two consecutive Glasgow Coma scores of less than 14 during any hour within the first 24 hours of treatment. Secondary outcomes include clinically apparent brain injury and short-term memory during treatment of DKA and memory and IQ 2 to 6 months after recovery from DKA. This study showed no significant differences among the four groups in the percentage of episodes in which the Glasgow Coma Scale score declined to below 14. Also in the magnitude of decline in the GCS score, as well as in the duration of time in which the Glasgow Coma score was less than 14. So in conclusion, neither the rate of administration nor the sodium chloride content of intravenous fluids significantly influenced neurologic outcomes of diabetic ketoacidosis in children. So in summary, we have presented the definition and epidemiology of DKA, discussed the pathophysiology, clinical presentation, the importance of clinical evaluation and the management during the early phase of recognition, and lastly, we in part uh, in part in part discuss cerebral edema, which is a dreaded complication of DKA. So thank you very much for your time and for listening.
Thank you so much, Dr. Cabarubias. It's time for our first Slido quiz. And here are the mechanics. Number 1, use your mobile phone to answer. 2, go to phone browser and type slido.com or scan the QR code flashed on the screen in order to go to slido.com. Number 3, enter the PIN code flashed on screen and input your complete name as username. 4, 3 questions will be asked based on the topic delivered. Number 5, the top 3 participants with the highest accumulated scores will be declared as winners of the round. Number 6, winners with incomplete names will be disqualified, and the next participant with the highest score and complete name will be awarded as a winner. Number 7, token per winner, 2 boxes of EasyVit multivitamins worth 810 pesos.
Hi and good afternoon. I am Raf and I will be your quiz master for today. As we are waiting for people to join our quiz, let me remind everyone to put your complete name as your username. As we wait for other people, let me call on some of our participants. We have Melanie Bagsit, Marpelita Helquina, Papa Pomelo, Cristela, Joanna Maria D.P. Diaz, Greta Alve, Mikel C. Mira Batad, Presi Padilla, Mira Batad, Mark Milan, and Fritz Rojo. We also have Florence Pulido, Clarissa Amos, Framela Urbano, Raquel Antonio, Ray Glenn Riverwen, Lavinia Elumba, Luisa, Irene Jordan. We also have on the list Andrew Louis Cabrera, Karen Socresa, Fort Louis, Rylin Leiran, Mea Cleto, Well, it seems like everyone is ready. Let us now start our quiz. Everyone have 15 seconds to answer our first question. Based on the answers that we have gathered, it seems that we have 37% who answered letter E. Let's find out the correct answer. The correct answer is letter A. For the next question, 15 seconds remaining to answer the second question. Based on the answers that we have collected, it resulted that we have 38% who answered letter C. Is it the correct answer? Let's find out. The correct answer is letter A. For the last question. For our last question, everyone have 15 seconds to finalize their answers. Based on the results that we have gathered, it resulted that 30% answered letter A. The correct answer is letter C. For our winners, in third place, we have Christian Leal. In second place, we have Riona Del Regojo Reyes. For our first place, we have Ellen May Sasam Acunio. Congratulations to our winners. We hope you enjoyed our quiz. For those who did not win, don't worry. You still have a chance later in our second quiz. Good luck. And now, here is our AVP for today. Please enjoy.
Sepsis, a life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis and septic shock are major healthcare problems, impacting millions of people around the world each year, and killing between 1 in 3 and 1 in 6 of those it affects. Shock is common in critically ill patients with COVID-19, developing in up to 67% of patients in intensive care, and is associated with high mortality. In the recent guidelines issued on care of critically ill adult patients with COVID-19, norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. But sepsis and COVID-19 do not only affect the health of the patient. Sepsis and COVID-19 can cause financial burden and has an impact in the environment as well. Although there are positive effects brought about by the lockdown, there is a growing concern in the increasing medical waste generated from hospitals and public's use of disposable safety equipment. Brought about by sepsis and COVID-19, there is a need for an ideal norepinephrine solution to manage hypotension due to shock to achieve mean arterial pressure greater than 65 mm per mercury. A cost-effective norepinephrine to help alleviate financial burden, a norepinephrine that cares for the environment. Norepin is an ideal norepinephrine solution based on clinical studies and guidelines. Norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. Norepin passed the Institute of Pharmaceutical Sciences National Institute of Health in UP Manila with an assay test result of 106.7%. Norepin is cost-effective compared to the Innovator brand and can provide a savings of up to 23,000 pesos. Norepin 10 ml preparation can cut the number of ampules to be opened by 40% compared to the Innovator brand. Thus, it helps lessen the medical wastes. Moreover, Norepin 10 ml preparation has the following advantages. Be a part of our CSR advocacy and world vision. Your prescription doesn't just save lives, but transform the lives of these children in World Vision. Every time you request Norepin at the pharmacy means sending a child to school and help fulfill their dreams.
Our second speaker is Dr. Maria Victoria A. Samonte. Doc Ria is a graduate of UP College of Medicine as a scholar. She then completed her residency training in pediatrics and pediatric critical care fellowship training at UP PGH. Currently, she is a research associate on burn, shock, trauma immunology, and a fellow of critical care medicine at Loyola University Medical Center, Maywood, Illinois, USA. She is also a clinical fellow on pediatric solid organ transplantation, pediatric academic multi-organ transplant program at the Hospital for Sick Children, University of Toronto, Canada. Doc Ria is a fellow of the Philippine Society of Critical Care Medicine, a diplomate of the Society of Pediatric Critical Care Medicine Philippines, and the Philippine Pediatric Society. She is a well-respected pediatric intensivist locally and internationally. She is currently the medical director of Abbott in Chicago, Illinois, USA. She is a content writer and reviewer of Pediatric on Call, member of the Association of Clinical Research Professionals, member of the editorial board of World Federation of Pediatric Intensive and Critical Care Societies, and a member of the Transplantation Society of the Philippines. To talk on blood sugar monitoring in PICU, understanding the highs and the lows, here is Dr. Maria Victoria A. Samonte.
A pleasant afternoon to everyone. I would like to thank Delex and the organizers for inviting me to talk to all of you today about the highs and lows of blood glucose in the critically ill child. I have no disclosures and no conflict of interest. For today, I will mainly focus on dysglycemia in critically ill children, how to evaluate and assess this condition, and I will briefly walk you through some recent evidence on glucose measurement and control in the ICU. As we all know, glucose fuels all organ systems in the human body. Although glucose has important effects on all organs, we must remember that glucose is the primary energy source for the brain and central nervous system. The classical symptoms of hypoglycemia and hyperglycemia are primarily neurologic in nature. This point is very important for all of us who treat and manage pediatric patients, as glucose disturbances in this age group may have a significant impact on brain development and function. Furthermore, it is very important to remember the organs that drive glucose regulation, as dysfunction or failure of any of these organs during critical illness will likely result in dysglycemia. Dysglycemia is a broad term that refers to an abnormality in blood glucose levels. This includes hypoglycemia, hyperglycemia, and glycemic variability. Critical illness triggers a number of inflammatory, immunologic, metabolic, hormonal, and neuroendocrinologic responses. These mechanisms and responses result in and exacerbate glucose disturbances in a critically ill child. As shown in this diagram, dysglycemia results from interactions between counter-regulatory hormones as well as an increase in pro-inflammatory mediators. This table presents the definition, causes, risk factors, and common outcomes of the three main dysglycemic conditions. The definition of hypoglycemia in critically ill children is not quite established, although several experts have proposed setting the blood glucose threshold based on clinically significant outcome measures. In critically ill neonates with increased metabolic demands, blood glucose less than 40 to 45 milligrams per DL is associated with abnormal neurological outcomes, such as diffuse basal ganglia, neuronal injury, and death. Beyond the neonatal period, blood glucose less than 60 to 65 milligrams per deciliter is associated with increased length of hospital stay and increased mortality. Stress hyperglycemia is common in pediatric critical illness, with a number of studies demonstrating that approximately 49 to 72% of children have blood glucose concentrations greater than 150 milligrams per deciliter, and as many as 20 to 35% of critically ill children have blood glucose concentrations greater than 200 milligrams per deciliter. The formal definition of critical illness hyperglycemia is a blood glucose of greater than 150 milligrams per deciliter occurring as a result of stress and resolved spontaneously after resolution of illness in patients without diabetes. Glycemic variability is a non-stationary state wherein there is fluctuation of blood glucose levels over a period of time. Traditionally, glycemic variability is defined as the occurrence of hypoglycemic and hyperglycemic episodes in the first 7 days of ICU stay. Take note, though, that this is not a rigid definition, especially in terms of the number of days, as this condition of glycemic variability continues to be further studied and explored by different groups. In the interest of time, I'm not going to go over each and every one of the causes, risk factors, and outcomes of dysglycemia. I want to point out, though, that the three dysglycemic conditions have similar risk factors and outcomes. Also, it is very important to note that several studies have found that glycemic variability is more strongly associated with increased mortality, increased occurrence of MODS, and overall poor prognosis compared to hypoglycemia or hyperglycemia alone. These are the typical signs and symptoms of hypoglycemia and hyperglycemia, which are mainly adrenergic and neurologic in nature. These clinical signs and symptoms of dysglycemia may be masked, particularly in critically ill patients. Pediatric patients may be unable to recognize or communicate hypo or hyperglycemic symptoms because of their young age, altered mental status, intubation, or severity of disease. This highlights the importance of employing a more objective determination of blood glucose levels in order to establish an accurate evaluation of the glycemic status of a critically ill child. The measurement or quantitative determination of blood glucose levels is an important and valuable tool in the management of critically ill children. There are three common blood glucose measurement devices: a central laboratory diagnostic device, blood gas analyzer, and a point-of-care glucose meter or point-of-care glucometer. The standard reference for blood glucose measurement is the analysis done in the central lab, although we all know that this method takes a relatively longer time to process and get the results from. Because of this, methods for blood glucose measurements at the patient's bedside or in the ICU itself are preferred from a logistical point of view. The older blood gas analyzers are quite large in size and require an allocated space in the ICU. There are, however, new generation blood gas devices that are smaller in size and can be used at the patient's bedside. It is important to know the proper type of blood sample, the method of collection, and the method of analysis employed by each of these three diagnostic devices. It is also important to know the differences, advantages, and limitations of each of these modes of measurement so that you can utilize them accordingly based on your patient and need. There are differences in blood glucose results depending on the source of the sample. For example, blood glucose results from plasma is approximately 10% higher than the results from whole blood. Recent real world studies comparing newer generation point of care glucometers with central lab tests showed that their accuracy is comparable in ICU as well as in non ICU settings, falling within the limits of quality standards. A number of clinical studies have evaluated and compared the methodological aspects of blood glucose measurement in the ICU. There are two published systematic reviews that analyzed results from clinical studies of critically ill adult patients, which assessed accuracy of blood glucose monitoring by ABG analyzers and glucometers by using central lab methods as a standard reference. The main findings and conclusions of both these systematic reviews are similar, so I combined the key conclusions here in this diagram. The blood compartment from which the specimen was extracted may affect blood glucose readings. The studies found that blood glucose measurements using arterial blood were significantly more accurate than measurements using capillary blood. Blood glucose monitoring with ABG analyzers tends to be more accurate than that with glucose meters using arterial blood. The reasons for this would be that glucometer readings may be affected by numerous factors unique to the critically ill patient, including perfusion and hemodynamic status, the presence of edema, hematocrit values, pH values, and oxygen tension. That said, the studies also found that the new generation point of care glucometers may be a good alternative. It is important to note that these conclusions were based on results from clinical studies and should be interpreted with caution because of study design heterogeneity. Nonetheless, one key message that we can take away is that blood glucose results are influenced not only by the diagnostic device used to measure glucose levels, but also by the specimen type and the patient factors that are present. We just talked about studies that compared the accuracy of glucose measurement devices among critically ill adults. What about studies in critically ill children? There have been at least 3 published studies that have assessed and compared the accuracy and validity of different glucose measurements in the pediatric ICU setting. This study evaluated critically ill infants and compared the glucose meter and the standard blood glucose analysis by central lab. The results of this study revealed that there was a significantly positive correlation between the two diagnostic methods. This study also showed that the glucometer was appropriate to use for rapid screening and frequent monitoring of blood glucose levels, although there were limitations found in terms of diagnosing hypoglycemia in the study population of critically ill infants. This is another study that compared the blood glucose readings obtained from the central lab and those from capillary blood using a glucometer in critically ill children with shock. Just like the previous study, there was a positive correlation found between the two types of measurements, and there was no significant difference noted in blood glucose readings between patients with and without peripheral edema. There was a mean difference of 6 milligrams per deciliter between laboratory glucose and capillary glucose, with wider differences observed at the higher ends of blood glucose levels. Overall, this study demonstrated that in pediatric patients with shock, capillary blood glucose readings using point-of-care glucometer were similar to central lab glucose readings in the mid-range values. This third study evaluated the accuracy of bedside glucometers using capillary, venous, and arterial blood samples and compared these blood glucose measurements to those by central lab. Results of the study revealed that peripheral hypoperfusion was associated with low accuracy of capillary blood glucose readings. Results also revealed that blood glucose measurements using arterial blood samples had more accurate results compared to those obtained from capillary blood samples. Based on their results, this study concluded that blood glucose measurements using capillary blood from critically ill children with peripheral hypoperfusion need to be interpreted very carefully. As we have seen from the clinical studies, measuring blood glucose using capillary blood samples has its advantages and limitations. It certainly is a preferred and convenient way of measuring blood glucose, especially in the ICU, at the patient's bedside, since there is a need to closely and frequently monitor the blood glucose of our critically ill patients. Here are some important tips and reminders on testing capillary blood glucose to help ensure proper technique and optimal blood glucose readings. For appropriate collection of the blood specimen by puncture, remember that the puncture site should be highly vascular, not highly innervated, to prevent patient injury or harm. The preferred puncture site in children is the lateral aspect of the fingertip. Avoid pricking the tips of the patient's fingers. In infants, the preferred puncture site is the lateral or medial aspect of the heel, and the puncture should be no deeper than 2 millimeters or 0.01 inches. Upon puncture, the blood specimen should flow freely. To help ensure this, it is acceptable to apply light intermittent pressure to encourage blood flow prior to puncture. Do not milk the site, as this will cause hemolysis and generate inaccurate blood glucose readings and values. As also noted in clinical studies, in order to have more accurate blood glucose results, it is important to avoid puncturing previous puncture sites, areas of inflammation, edema, bruising, or infection, cyanotic or poorly perfused tissue, areas with low skin temperature, and sites with superficial arteries. Based on what we have discussed so far, and based on current clinical evidence, we can gather several key lessons learned in terms of blood glucose testing and measurement. First, the accuracy of blood glucose measurements and results are mainly influenced and dependent on the diagnostic device utilized, the source of the sample in terms of the blood compartment, and the condition of the patient, particularly in terms of hemodynamic and perfusion status. Always consider and keep the following in mind when planning and deciding on blood glucose testing to help ensure having optimal blood glucose measurements and results. Who is the kind of patient you will be doing the test on, and what is the patient's condition? What blood glucose test and type of sample are most appropriate and will best help you in the evaluation, management, and care of the patient? Where are you doing the blood glucose test? Was it in the ICU, in the ER, in the wards, or in the clinic? Why are you doing the test? What is the reason and indication for checking the patient's blood glucose? In connection to the why, how should the blood specimen be collected to yield optimal results? How often does your patient's blood glucose need to be measured and monitored? How fast do you need the results to help optimize patient care? It is important to recall that several variables can potentially interfere with blood glucose measurement accuracy. Because of this, The interest in real-time continuous glucose monitoring, or CGM devices, especially in the ICU setting, have been recently explored and assessed. CGM devices are wearable or implanted medical devices designed with sensors which measure glucose levels 24 hours a day. A transmitter sends the results to a wearable device or cell phone. The advantages of CGM is the elimination of frequent finger pricks or finger stick tests, as well as time saved checking blood glucose often. CGMs can also help lower the exposure risk of healthcare workers performing assisted monitoring of blood glucose. At the current time, CGM devices are US FDA approved for use in patients with diabetes and not currently approved for inpatient use. That said, CGM device systems have been evaluated in clinical studies for the ICU population. To date, there have been at least 43 clinical trials that have evaluated CGM use in ICU settings for critically ill adults. Majority of these adult studies have demonstrated effectiveness and benefit of CGM use in the ICU. To date, there are at least 7 clinical trials that have assessed CGM use in the pediatric ICU setting. These studies looked at children with COVID-19, sepsis and septic shock, post-op patients, as well as those who underwent stem cell transplant. CGM use was of benefit, especially in terms of monitoring glucose trends and rates of change, correlated well with blood glucose values, and guided the treatment of dysglycemia. There were few limitations noted in the studies, though. One study of 16 patients noted a tendency of CGM to underestimate blood glucose values. Another study that included stem cell transplant patients noted suboptimal accuracy. Because of the potential value add of this diagnostic device, especially in the ICU setting, more research and clinical investigations are being conducted on this promising technology. In the field of adult critical care medicine, determination of HbA1c on admission has shown diagnostic and prognostic value. It has yet to be assessed and established whether glycosylated hemoglobin would be of diagnostic value for pediatric critically ill patients. As we all know, laboratory tests are tools that serve to guide our clinical evaluation and patient management. After all, we are meant to treat our patients, not the laboratory test. Laboratory tests should always be correlated to the overall clinical picture and findings. With that being said, the main objective of blood glucose measurements is to provide glucose levels for us to determine the status of our patient and what to do next. The next questions would be, are there certain blood glucose values that require treatment? Is there a specific blood glucose concentration range that I should be aiming for? For many years, the answers to these questions are still being debated and discussed in the medical community. Based on analyses of clinical evidence, the American College of Critical Care Medicine has suggested a target blood glucose in the range of 100 to 180 milligrams per deciliter as being a reasonable goal for critically ill pediatric patients. In the latest Surviving Sepsis Campaign international guidelines, the consensus was to target glucose levels below 180 milligrams per deciliter for children with septic shock. In a very recent systematic review, a blood glucose target of 140 to 180 milligrams per deciliter was recommended for critically ill patients. It is important to keep in mind that though these recommendations are robust and evidence-based, we need to remember that guidelines are meant to guide and are not meant to define actual patient treatment. Like I have always said and maintained, the best guide to appropriate patient management is the patient. I'm not going to spend too much time discussing the treatment of dysglycemia in critically ill children in this lecture. However, I think it is important to touch on glycemic control regimens, as these are closely tied to why blood glucose measurements are important. There have been several clinical studies that evaluated and compared the efficacy of tight glycemic control, or TGC, versus the standard conventional control. Majority of clinical studies conducted in both critically ill adults and children did not note any significant benefit with tight glycemic control. In addition, severe hypoglycemia was the most common adverse effect observed among TGC patients. Before I conclude my talk today, I want to summarize and reiterate some key points. Dysglycemia is a common occurrence in all critically ill patients and leads to very significant and serious adverse patient outcomes if not identified, addressed, and managed appropriately. We need to always remember that dysglycemia and its management are dynamic processes, which further emphasizes the importance of intensive patient monitoring and evaluation. For blood glucose testing, always consider the who, what, where, why, and how. It is very important to be familiar with the proper use of blood glucose measurement devices and techniques. For appropriate and optimal patient management, always remember to address the root cause of the problem, and always remember to treat your patient, not the test result. Thank you for your participation, and continue to keep safe and take care of one another. Thank you.
Thank you so much, Dr. Samonte. It's time for our second Slido quiz. And here are the mechanics. Number 1. Use your mobile phone to answer. Number 2. Go to phone browser and type slido.com or scan the QR code flashed on the screen in order to go to slido.com. Number 3. Enter the PIN code flashed on screen and input your complete name as username. Number 4. 3 questions will be asked based on the topic delivered. 5. The top 3 participants with the highest accumulated scores will be declared as winners of the round. Number 6. Winners with incomplete names will be disqualified, and the next participant with the highest score and complete name will be awarded as a winner. Number 7. Token per winner, 2 boxes of EasyVit multivitamins worth 810 pesos.
Hi, good afternoon. It's me again, Raf, and I know everyone is eager for our second quiz. But before we start, let me remind again everyone to put your complete name as your username. As we wait for other people, let me call on some of our participants. Lionel C. Mascarina. Hi there, Geraldine Gonzalez. We also have Mary Rose Mayao. We also have Julie Mako. Also on the list, we have Olive Perez. We also have Cramina Dizon. Well, it seems like everyone is ready. Let us now start our quiz. We only have 15 seconds to answer the first question. Based on the answers that we have gathered, it seems that there are total of 42% of people who answered letter B. Is it the correct answer? Let's find out. The correct answer is letter B. Congratulations to those who answered letter B. For the next question, we only have 15 seconds remaining to answer the second question. Based on the answers that we have gathered, it seems that there are 44% who answered letter D. Well, what is the correct answer? The correct answer is letter C. For the last question, we only have 15 seconds to answer the last question. Based on the answers that we have gathered, it resulted that there are 65% of people who answered letter D. What is the correct answer? The correct answer is letter D. Good job. Now, for our winners. For our winners, in third place, we have Allen Palon. On second place, we have Japet Mananansanan. On third place, we have Pamela Campos. Congratulations to our winners. We hope you enjoyed our quiz. Now, I give back the floor to you again, Brad Pitt.
All right, there you have it, ladies and gentlemen. It's time for a Q&A. We encourage everyone to type in their questions to the Q&A box. I am pretty sure you have lots of questions for our two brilliant speakers. To answer your questions, I would like to bring you back our speakers, Dr. Paul D. Cabarubias, Dr. Maria Victoria A. Samonte, together with our moderator, Dr. Jerusel R. Bugay. To the virtual stage, doctors.
Hello, everyone, and welcome to the question and answer portion of our webinar. Let me first greet as well our excellent speakers, Doc Paul and Doc Ria. Good afternoon.
Good afternoon, Jero. Hi, Ria.
And to our participants, please keep your questions coming and let's make this a very fruitful virtual learning experience for all of us. So let me start with Doc Paul. So Doc Paul, I think that is a very comprehensive lecture on DKA diagnosis as well as the many aspects of DKA management. But there is a very practical question here from our viewers that since DKA is already a complication of a long-standing untreated diabetes, the viewers would like to know what are the signs and symptoms that we are actually dealing with a diabetic child and therefore should get tested.
Yeah, actually, Jero, not all patients who will present with DKA has a long-standing elevation of blood sugar or been diagnosed previously with diabetes, because most of these patients at the emergency room coming symptomatically are undiagnosed DKA. So basically, most of these children would have a precedent infection or concurrent infection that could have triggered the DKA. But sometimes those patients with no current infections, they may present with weight loss, fatigue, increase in urination even at night, and decrease in energy. And for smaller children, some would even present with cutaneous candidal infection or diaper rash that would point out a possible elevated blood sugar.
Okay, so I hope that's clear. So we have some clinical signs and symptoms that we can see with our kids to say that whether they should get tested for diabetes. So it's really, DKA is really preventable with early diagnosis and treatment of diabetes. Thank you, Doc Paul. So for Doc Ria, I think that is a very beautiful lecture. It gives us a clear understanding of the concept of dysglycemia in critically ill children. So my first question would be on how to monitor, ma'am. So what is really the best sample to use for blood glucose monitoring, particularly in the ICU setting? And how frequent do we really need to monitor them?
So again, based on the evidence, right, and most of the clinical studies in both adults and children, it seems that arterial blood samples are the ones that provide the most accurate results in terms of blood glucose levels. So if you had an ICU patient, I think that's the value of having an arterial line. If you're able to put in an arterial line in those patients, that would be better. So that can avoid frequent punctures and frequent blood extractions. Now, that being said, if you cannot have an arterial line put in place, of course, using capillary blood is also acceptable as long as the proper technique is done.
Okay, ma'am. How do we determine the frequency of monitoring of our blood glucose?
So the frequency is really dependent on, I guess, the condition of the patient, right? So there are general rules and general guidelines, so to speak, on how often you should monitor patients, especially when you've noticed that they either have hypoglycemia or hyperglycemia. So the general recommendation is to monitor after you give the first, let's say for hypoglycemia. We'll just talk about hypoglycemia first because that's easier. So in a patient who is hypoglycemic, after you give the first dose of glucose, IV glucose, either D10 water, then you repeat or you do the test, the glucose test, 15 to 30 minutes after the first dose. And then, depending on the response of the patient, until the glucose, once you see stable glucose levels, you can monitor it every 30 minutes to 1 hour. Again, until the patient's glucose levels are stable. But again, I really need to emphasize that is not like a black and white kind of rule, right? Again, it depends on the patient, and also I guess we need to ask ourselves all the time, what is the diagnosis of the patient, right? What is the assessment and what is the condition of the patient? Why am I testing for the glucose? If it's just for a matter of just knowing what the glucose levels are, then without doing anything about it, then it's just going to be a little, it's not going to be very useful and of value to patient care. Again, we do the glucose test in order for us to guide our treatment plan and our management plan, and not just to note what the actual values or numerical values are.
Yes. So the best sample is arterial based on the recent evidences, and the frequency of monitoring should be dictated by the patient's condition. So thank you, Doc Ria. For Doc Paul, insulin therapy is one of the mainstay of treatment of DKA. And there's a question here with regards to
Recording stopped.
insulin
Recording in
flushing-
progress.
insulin flushing of our IV tubings. Can you elaborate on this, sir?
Yeah, the one recommended is to not to give insulin as bolus, but to prime the tubings and the syringes with the insulin prepared solution.
Yes. So I think that is clear. So the recommendation is not to give insulin bolus, but more of priming the tubing by flushing it with insulin so that we can ensure already that insulin is being given continuously and properly. Thank you, Doc Paul.
Thanks, Jero.
Okay, for Doc Ria. So there is a question here regarding the difference of the results, whether we take our specimen from the tip versus the lateral aspect of the finger, because you have mentioned in your lecture that the proper site should be the lateral part of the finger and not really the tip.
Mhm. So I think first that's tied to the reason why we should avoid taking the blood or puncturing the tips of the fingers is because one, it is really a highly innervated site. Right. So, and that will really cause a lot of pain to the patient. And also, we need to also remember that pain in itself can actually also affect and influence glucose levels. Right. So you're adding stress to the patient, and that can, alter your overall glucose picture and diagnosis in that way. I think the question was also about whether there are any clinical studies that compared puncturing the lateral side of the finger to the tips of the finger. I don't know of any clinical studies, but again, that being said, and I doubt that there would be any clinical studies, only just because, again, in general, we really should avoid the tips of the fingers because one, you're not going to get a lot of free flowing blood from that sample, and two, again, it is highly innervated. The tips of the fingers are highly innervated and can cause a lot of pain.
Okay, thank you, Doc Ria. So there are no studies yet whether there's a difference between the tip
Yeah, and
versus the lateral
I don't
side
think
of the
anyone's
finger.
going to do that, honestly, because it's again, it's really not. So it should not be done. Essentially,
Yeah,
I mean, puncturing the tips of the fingers.
thank you, Doc Ria. Okay, for Doc Paul, in resource limited settings where infusion pump may not be available, how can we give our insulin therapy?
Yeah, it's a common problem among small hospitals, no? But you can actually regulate your insulin drip using what do you call this? Yung Soluset, right? But usually the minimum delivery of Soluset is around 4 mils per hour or 4 cc per minute. So that's the minimum rate that you can accurately give your insulin drip. Lower than that is very difficult for the nurses. But when you're using, if you're going to use the Soluset, make sure that the nurses or even the interns or the residents are really monitoring closely the hourly delivery of the insulin drip.
Yes. So in the setting where we don't have a syringe pump or infusion pump, we can make use of our very friendly Soluset. But can you comment, sir, if we can give subcutaneous form of insulin in DKA patient, just in case that the running rate of insulin therapy may also not be feasible with the Soluset?
Yeah, for those kids who are not in severe DKA and the circulation is not bad or the perfusion is good, you can actually give subcutaneous insulin.
Okay. Thank you, Doc Paul. Okay, for Doc Ria, I think you discussed a bit on the management of dysglycemia. We always say in the ICU that we treat the root cause and not the symptom, but the main problem. But in case of dysglycemia, ma'am, when do we usually treat it? When do we decide to treat it? And how do we manage dysglycemia?
So just to clarify, when what you mean, I guess, is in terms of hyperglycemia.
Yes, ma'am.
Am I correct? Okay. Yeah. So I think one thing that we need to again keep in mind is that glycemic variability is actually a more severe dysglycemic condition, so to speak. So that's one. And the reason why I'm emphasizing that is that even if you note hyperglycemia in your critically ill patients, it does not mean that they're going to be hyperglycemic all throughout the course of their stay in the hospital. And again, that's why monitoring the glucose levels, once you note that there's some abnormality that's happening in terms of your glucose values, then and on closer monitoring, you look at the trends, right? Is my patient really persistently hypoglycemic or persistently hyperglycemic? Now, if you do note that on monitoring and looking at the trends, if you see that your patient is persistently hyperglycemic and has clinical symptoms, right, that require management and giving insulin, then that's when I would intervene. So examples of symptoms wherein I would intervene is if there is osmotic diuresis that is aggravating the shock or the hypovolemia of the patient, coupled with persistent hyperglycemia, then I would opt to start insulin in those conditions. Or in patients that have persistent metabolic acidosis, and I think that the hyperglycemia is also contributing to the acidosis, then I may also opt to start insulin. Or in patients that I'm also considering DKA in, right? So like Dr. Covarrubias had mentioned, DKA does occur and develop also in critically ill children. So then if I were to diagnose and assess that the patient is in DKA, then I would also start insulin then. But again, it's not just treating the value of the glucose by itself, but really looking at the overall picture of the patient and being clear on why you would want to start insulin in a hyperglycemic patient. Or maybe you can wait a little bit if you can and see how the patient responds to your immediate or emergent management first.
Okay. Thank you, Doc Ria. I think that's very clear that we always have to look our patient rather than just the laboratory values. Okay, for Doc Paul, you also mentioned, sir, about the 1 bag and the 2 bag protocols in the fluid therapy. Can you elaborate further, sir, on this? Because there's also a related question with regards to the maximum dextrosity that we can infuse in peripheral line.
Yeah. The 2-bag system is preparing a non-dextrose containing solution with the same electrolytes as the same solution having a D10 dextrose containing solution with the same quintet of electrolytes. And if you get a blood sugar around less than 200 milligrams per deciliter, you might want to, and there is still persistent of acidosis, you might want to increase already the dextrosity so that the patient won't develop hypoglycemia and to be able to give the insulin drip continuously.
So, sir, do you advise that the 2 bag protocol is better so that whenever there are fluctuations in the blood glucose, the nurses can readily infuse the correct fluids?
Yeah, it's very easy to increase the dextrosity of your present IV fluids than asking the nurses to prepare another solution having a different dextrosity.
Okay. And what is the maximum, sir, dextrosity for the peripheral line?
Yeah, for the question, for peripheral line, the dextrosity is it should be less than 12.5. But for central line, until dextrosity of 25 will be okay.
Okay, thank you, sir. Okay, for Doc Ria, there's a question here on what is the best way or best maybe how to address stress hyperglycemia at the emergency department?
Well, again, as I mentioned, it really depends on the case of the patient, right? So there is really no black and white rule on treating hyperglycemia. Again, assessing the cause of the hyperglycemia or whatever glucose abnormality you're noting. Of course, stabilizing your patient first. Remember that the reason why glucose disturbances happen or dysglycemia happens in critically or even acutely ill children is that it's the illness itself, right? So definitely aggressively address the condition of the patient, stabilize the patient. And then if you notice that there is still even after stabilization, if you still notice some abnormality in the glucose levels, then you can do the necessary further investigation into the cause. I would do that first before treating, and definitely I would avoid treating symptomatically.
I would definitely agree with that, Doc Ria. So we always treat the main problem So this innocent bystanders like the stress hyperglycemia is just a marker of the severity of illness. So we always treat the main cause.
Mhm.
Okay. I think we don't have any more questions. Maybe last one for Doc Paul. Since cerebral edema is the most common cause of mortality in DKA patients, can you give us like a clue if we are really dealing with a cerebral edema patients at the outset at the emergency department? And therefore, we should initiate treatment as well for the cerebral edema.
Yeah, contrary to what we know, that cerebral edema is a complication in the treatment of DKA. Patients, even without having given fluid resuscitation, can develop cerebral edema from the onset. So the earliest manifestation would be altered in the sensorium, so a drop in the Glasgow Coma scale. So all DKA patients should be monitored closely for their sensorium and the Glasgow Coma scale. And if there's a hint that there is a possibility of increasing intracranial pressure or a possibility of DKA, you don't have to do any laboratory workups, but already initiate therapy by initially by elevating the head of the patient. And if you're really entertaining cerebral edema, you might also already start giving your osmotic therapy.
Okay. Thank you, Doc Paul. And maybe last question for Doc Ria. So if we already started our blood glucose monitoring, when do we decide to stop the blood glucose monitoring, ma'am, in the ICU?
So again, it depends on the case of the patient and the condition of the patient. And I guess answering also the question, we just need to ask ourselves, why did we even monitor the blood glucose, right? So once we determine the condition of the patient, and then if the root cause of the glucose disturbance or the dysglycemia has already been addressed, then maybe at that point you can already discontinue glucose level monitoring. But again, it comes back to the patient and how happy you are with how the patient has been stabilized or managed, and how much of the critical illness has already been addressed.
Okay. Thank you, Doc Ria. So I think that is all the time that we have for the question and answer. At this point, I would like to ask our speakers for any takeaway message, Doc Paul and then Doc Ria for after.
Yeah, for children who's having symptoms, as mentioned before, that really points out the possibility of DKA, it's really very important to seek early consult so that to prevent the complication of DKA. So early manifestations should not be disregarded by parents and should be brought up with their attending physicians.
Thank you, Doc Paul. Doc Ria.
So I think there are just 2 points that I wanted to reiterate before we end. So one would be that we just need to remember that dysglycemia does occur in critically ill children. So our role as healthcare providers is to make sure that we identify it along with close monitoring, and also recognizing that dysglycemia more commonly will be more of glycemic variability. So it's not going to be permanent hypoglycemia or permanently hyperglycemia. So we just need to be able to, again, frequently monitor our patients. Addressing the root cause is definitely important. And that's first and foremost in anything, right? We're treating the patient, not the laboratory test. So a good guide in terms of blood glucose testing would be just remembering what I shared with all of you, the who, what, where, why, and how when you do blood glucose testing. And hopefully that will be helpful and simple enough for you to follow when you think about and plan your blood glucose evaluations.
Thank you, Doc Ria. So thank you, Doc Paul, Doc Ria, for that excellent discussion and also for sharing your best practices with us. So at this point, let me also thank the organizers for this webinar and for this opportunity. And of course, to all our fellow learning enthusiasts for your active participation and continued support in our PICU M.R.T series. So please remember, the next time you encounter a critically ill child, please don't forget to ask the question, how is this child's glucose? So, how to monitor and how to manage has been well discussed by our speakers. And it is now time to apply our learnings in clinical practice. So, with that, this is Doc Jero saying thank you and keep safe.
Everyone, thank you.
Thank you, Dr. Cabarrubias, Dr. Samonte, and Dr. Bugay for that interactive session. Now we would like to present these certificates. This e-certificate is presented to Dr. Paul D. Cabarrubias in grateful recognition and appreciation as speaker in PICU M.R.T Season 2, 5th Station. No sweet talk on blood sugar in PICU. Controlling sugars on the Rise, a talk on DKA in children, given this 20th of July, year 2022. Signed, Dr. Rodelia G. Cipriano, Program Director, and J. DeReuter C. Oroseo, Chairman and CEO. Thank you so much, Dr. Covarrubias. This next e-certificate is presented to Dr. Maria Victoria A. Samonte in grateful recognition and appreciation as speaker in PICU M.R.T Season 2, 5th Station. No sweet talk on blood sugar in PICU. Blood sugar monitoring in PICU. Given this 20th of July, year 2022. Signed, Dr. Rodelia G. Cipriano, Program Director, and J. DeReuter C. Oroseo, Chairman and CEO. And of course, to our great moderator. This e-certificate is presented to Dr. Jerusel R. Bugay in grateful recognition and appreciation as moderator in PICU M.R.T Season 2, 5th Station. No sweet talk on blood sugar in PICU. Controlling sugars on the Rise, a talk on DKA in children and blood sugar monitoring in PICU. Given this 20th of July, year 2022. Signed, Dr. Rodelia G. Cipriano, Program Director, and J. DeReuter C. Oroseo, Chairman and CEO. Thank you so much, Dr. Bugay. And to our wonderful participants, this e-certificate is for you for successfully completing the 2-hour webinar on PICU M.R.T Season 2. 5th Station. No sweet talk on blood sugar in PICU. Controlling sugars on the Rise. A talk on DKA in children and blood sugar monitoring in PICU. Given this 20th of July, year 2022. Signed, Dr. Rodelia G. Cipriano, Program Director, and J. DeReuter C. Oroseo, Chairman and CEO. And together with your e-certificates, you will receive this self-directed learning application form, which you have to submit to PRC to apply for CPD credits. And to formally close this afternoon session, let us welcome one of the hardworking district managers of Delex Pharma. Here's Mr. Kjell Ruiz.
Thank you for attending our PICU M.R.T Tip Stop today. We have gained knowledge and understanding in No Sweet Talk on blood sugar in PICU. We would like to express our heartfelt gratitude to one and all. From our excellent lecturers, Dr. Paul D. Covarrubias and Dr. Maria Victoria A. Samonte, up to our pediatric ICU faculty. Your dedication and effort in making this pediatric ICU forum successful are embedded in our hearts. We hope that the valuable information and best practices shared by our distinguished speakers will be a guiding light to your profession. Likewise, this added knowledge should pave the way to inspire you to think of new ways how to be the best partners in providing quality healthcare to your patients and customers. Secondly, Delex Pharma International Incorporated aims to bridge the gaps in critical care by providing quality and cost-effective medicines and medical devices to the greatest number of people. The hospital sales representatives and district sales managers visiting you in your respective pharmacies, critical care units, operating theaters, and emergency rooms will ensure that they can fulfill these vital roles during their engagements with you. We hope to continue and grow the partnership with you to provide the best quality healthcare to all. Maraming salamat po.
If you got some inquiries or questions for Delex Pharma,